afternoon, and welcome to Psychiatry Grand Rounds. There is no commercial support. The planners have disclosed no relevant financial relationships with commercial interests. Our speaker will announce his disclosures. If you have a question for the presenter, please hold until the Q&A segment at the end of the presentation. If you're attending virtually, please click the sign-in link in the chat section. And if you have a question, there will be a specific Q&A bubble that you will enter your question into, and a link to the event evaluation will be shared at the end of the program. It is my pleasure to introduce Dr. Brian Miller. Dr. Miller is a professor with tenure in the Department of Psychiatry and Health Behavior at Augusta University. He earned a BS in mathematics from Vanderbilt University, a combined MD, MPH degree from the Ohio State University, and a PhD in psychiatric epidemiology from the University of Oulu, Finland. He completed his general psychiatry residency and fellowship in psychotic disorders at Augusta University, where he served as chief resident and joined the faculty in 2010. Dr. Miller's current research focuses on insomnia and suicide in schizophrenia and has been funded by the National Institute of Mental Health, the Stanley Medical Research Foundation, and the Brain and Behavior Research Foundation. He has over 100 peer-reviewed publications. He has been recognized with several awards, including the 2011 Exemplary Psychiatrist Award from the National Alliance on Mental Illness, the 2015 Augusta University Outstanding Young Clinical Science Faculty Award, the 2017 OSU College of Medicine Early Career Achievement Alumni Award, and a 2020 Distinguished Fellow of the American Psychiatric Association. He has been an editorial board member of Biomarkers in Neuropsychiatry, BMC Psychiatry, Current Psychiatry, Schizophrenia Bulletin, and Psychiatric Times. In addition to his research, Dr. Miller provides clinical care for patients with schizophrenia, serves as the Associate Director for the Psychiatry Clerkship, and supervises and teaches residents and medical students in general psychiatry. Please join me in welcoming Dr. Miller today.
Hello, everyone. Thank you very much for that very kind introduction. It's a pleasure to be with you virtually today and look forward to talking to you about the work that we've been doing with regards to insomnia and suicide in our patients with schizophrenia. So to make things official, I've included my list of disclosures. There are no specific disclosures that are relevant to the present talk. I would also like to disclose that, as you can probably tell, I am in fact bald, but that's okay because in DSM-5 they actually changed the diagnosis of male pattern baldness, and so it's now called follicular disability. So I appreciate that very much. We will talk about some off-label investigating use of a particular product that's called the Neuroptics PLR 3000 pupilometer. I'm actually going to take 2 seconds and show it to you virtually. This is the pupilometer. It looks like a big kind of glorified auto ophthalmoscope, and we'll be talking about our work trying to develop this as a potential point of care test for suicide risk. So that will come later. Our objectives today, I want you to be able to assess the evidence for associations between insomnia and psychopathology in our patients with schizophrenia and other psychotic disorders. We'll talk about the associations, the evidence between insomnia and suicide risk in these same patients. And then lastly, we'll talk about the use of pupilometry as a novel marker of suicide risk across psychiatric diagnoses. So again, we'll begin simply following the objectives. We'll talk about insomnia in patients with psychosis as it relates to pathology and then suicide. And then we'll finish by sharing some of our work in pupilometry. So needless to say, working in clinical psychiatry can be tiring. This is my daughter when she was about 3. She's now 9, going on maybe 19. We've all been tired. I'm not so sure that any of us have been so tired that we fell asleep mid-bite with a chip in our mouth, but alas, that can happen. Of course, as psychiatrists, we look for behavior patterns. And so here she is again, falling asleep mid-bite. You'll be fortunate to know that she does not have narcolepsy. And in fact, these are maybe about the only 2 times that in her life that her mouth has remained closed. She's quite lovely and gregarious. So with that comedy aside, let's talk about associations between sleep disturbances and suicide risk in our patients with psychiatric disorders. So this forest plot here is a meta-analysis that was done of associations between sleep disturbances and suicide risk that was transdiagnostic, and just draw to your attention the fact that overall any sleep disturbance was associated with about a 2-fold increased risk of suicidal thinking and behaviors. So sleep disturbances as well, when we look at kind of specific types of sleep disturbances, strongest associations have been found for insomnia, which was a significant predictor of suicidal ideation, again, adiagnostically, and then nightmares, which also were a significant predictor of suicide attempt, again, almost a 2-fold increased odds of suicide attempters in patients with significant nightmares. So our former chair, Vaughn McCall, had done a lot of work both at Wake Forest and here in Augusta on insomnia as a risk factor in suicide for patients with depression. He suggested that we take a look at this in schizophrenia, and over the past about 5 years or so, we've kind of been off to the races, so to speak, looking at these associations in our patients with schizophrenia and other psychotic disorders. So we know that both of these, unfortunately, are very common phenomenon. Insomnia is highly prevalent in the range of somewhere between 1 in 4 and 1 in 2 patients will complain of insomnia. We know that approximately 1/4 of our patients with schizophrenia will attempt suicide during their lifetime, and unfortunately, about 5% of our patients will die as a result of suicide. And this is particularly striking given the fact that we know that neither insomnia nor suicide are part of the diagnostic criteria for psychotic disorders. And when we look at our main individual items in various psychopathology rating scales, most commonly the PANSS, or positive and negative symptom scale, again, insomnia and suicide are not individual items. So how do we begin this line of research? Well, step 1 was let's play in the backyard. Let's take a look at some data we had already had, and at Dr. McCall's suggestion, we started collecting using the Beck scale for suicide ideation, as well as what's called the ISI, which is the Insomnia Severity Index. And we collected data on about 100 of our patients, roughly half with schizophrenia, the other half with schizoaffective disorder. Mean age was early 40s. The sample was about 2/3 male, about 2/3 Black. And again, we collected just at a single time point these measures of both sleep and suicide. And so current insomnia is assessed over the past 2 weeks using the ISI. That scale has 7 items that are rated between 0 and 4 on a 5-point Likert scale. So the total score range for the ISI ranges from 0 to 28. Suicidal ideation over the past week, as well as a lifetime history of suicide attempt, again, were assessed using the Beck scale for suicide ideation. The Beck scale has a total of 19 items rated between 0 and 2. So the total score range for the Beck is 0 to 38. And what did we find? We found that after controlling for a number of important potential confounding factors, including age, sex, race, smoking status, BMI, and socioeconomic status, that the severity of insomnia as a continuous measure was a significant predictor of the Beck Suicide Scale total score, with a modest but significant correlation of about 0.27. Now, when we looked at insomnia categorically, we found that severe insomnia was associated with about a 13-fold increase in Beck scale scores compared to those with no clinically significant insomnia. And furthermore, patients with severe versus no insomnia were about 15 times more likely to have a history of suicide attempt. When it came to the severity of psychopathology, again, using the PANSS, we found that insomnia scores were significantly correlated with total psychopathology as well as positive and negative psychopathology. So some very interesting preliminary findings there. So the next step was to invite several friends over to play. I came across an abstract from a group in China that appeared to have the same relevant data. They used the Insomnia Severity Index again, as well as this time they used the Calgary Depression Scale for schizophrenia, which has an item asking about suicidal ideation in the past 2 weeks, which we dichotomized as either present or absent. So this time these were inpatients with chronic schizophrenia, again, mean age early to mid 40s, and a sample that was predominantly male. When we looked at the insomnia score as a continuous measure, we found, again, a significant increased odds of current suicidal ideation, again, as a categorical yes-no variable. When we looked at the insomnia score categorically, higher levels of insomnia were associated with about a 2.5-fold increased odds of suicidal ideation. And we found that in subjects with suicidal ideation, there were about 24% who had insomnia versus only about 10% of those patients without insomnia. In that study, again, it's the same pattern when we looked at correlations with psychopathology. The insomnia scores were significantly correlated with total psychopathology, positive psychopathology, and general psychopathology, but not negative symptoms. So following this replication, we decided, hey, could we throw some kind of big party? What was the largest potential data set that we could look at? And we're very fortunate to have on our faculty Dr. Joe McAvoy, who is the chief clinical officer of the large CATIE schizophrenia trial, which you may recall was over 1,400 subjects with schizophrenia or schizoaffective disorder. These data are publicly available and can be requested and obtained fairly easily. And so again, mean age of subjects, early 40s. The CATIE sample was about 3/4 male. Again, about roughly 2/3 to 1/3 Black versus white. The CATIE study also has data on from suicide on the Calgary Depression Scale. The Calgary Depression Scale also includes a specific item assessing only terminal insomnia, that is early awakening, asking patients if they wake earlier in the morning than is usual for them. There's also a separate self-report item that was obtained at baseline in CATIE that asked about initial or middle insomnia. And it also asked about suicide attempt within the past 6 months. And so what did we find in the CATIE trial? Again, very concordant with previous findings. We found that if patients had terminal insomnia at the baseline visit of the CATIE trial, again, about a 2.5-fold increase odds of having suicidal ideation at that time. We found a similar association with slightly smaller effect for either initial or middle insomnia. And we found that if patients had terminal insomnia at baseline, that was also associated with about a 5-fold increased odds of having had a suicide attempt within the past 6 months. Interestingly, only terminal insomnia was associated with recent suicide attempt. In this data set, neither initial nor middle insomnia were associated with that, again, suicide attempt in the past 6 months. Kind of batting 3 for 3. Again, we found that levels of insomnia, having insomnia was associated with, again, higher total positive and general psychopathology. So very intriguing that we found great consistency across all 3 of these initial data sets. Just a interesting point. We know that sleep disturbances are also associated with inflammation and other metabolic risks. And we found that the presence of insomnia was also associated with, again, a small effect, but statistically significant, higher levels of triglycerides across the first 6 months of the CATIE trial. When we looked at that categorically, there was almost an association at baseline, but interestingly, patients with terminal insomnia at CATIE baseline were almost 4 times more likely to have clinically significant hypertriglyceridemia after their first 3 months on treatment with olanzapine. So after these 3 data sets, we began to consider where else we might investigate this association. And again, looking at publicly available data sets, there is what's called the RAISE, Recovery After Initial Schizophrenia Episode. That's a recent cohort of over 400 patients with first episode schizophrenia. So again, their mean age, much younger, 24, predominantly male sample, predominantly patients of African descent. The RAISE trial has the Calgary Depression Scale. In addition to that, they also have a self-report item on the presence or absence of sleep problems. And so what did we find? If I can distill this kind of busy table for you, consistent with all of our other findings, at baseline, the presence of any sleep problem was associated with about a 2-fold increased odds of current suicidal ideation. We did note that that association was attenuated and no longer significant after we controlled for depressive symptoms. However, interestingly, if you looked at patients who had consistently had sleep problems at every visit over the 2 years of the RAISE trial, those patients, even after controlling for their depressive symptoms, were almost 8 times more likely to have suicidal ideation at some point during the 2 years of this trial. So again, broadly consistent findings between the presence of insomnia and higher suicide risk. Across the 24 months of the RAISE trial, to distill this down, again, largely statistically significant associations at every time point over 2 years. When patients have insomnia, they have worse positive and general psychopathology, leading to greater total symptoms. So thus far, all of the studies that we had done focused primarily on patients at a single time point. We also had an opportunity to look at more longitudinal associations between insomnia and suicide risk. And to do that, we utilized the NIMH PROACTIVE trial. PROACTIVE was a trial lasting up to 30 months in over 300 patients with schizophrenia or schizoaffective disorder. And these patients were randomized to treatment with either oral second-generation antipsychotics or risperidone. Again, mean age was approximately 40, a largely male sample. This time, about 2/3 of the sample was white. In this case, for this trial, there were not any more objective measures of insomnia. Instead, we looked at insomnia just as being reported as an adverse event during the trial. However, there were data on depression and suicide on a biweekly monitoring assessment. What we found here at study baseline, patients with moderate to severe insomnia had, again, about a 2.5-fold increased odds of current suicidal ideation. Again, that not only the consistency of the association, but also the magnitude being very similar across different studies. At the other individual time points, where unfortunately a lot of patients were lost to follow-up, there weren't any statistically significant associations. However, if patients had moderate to severe insomnia at baseline, they were about 2 times more likely to have suicidal ideation at any point throughout the trial. The proactive trial did not utilize PANSS. Rather, it was a more of a kind of a self-derived measure of psychopathology, but even using that broadly different rating scale, we again found significant correlations between the presence of insomnia and total psychopathology, not only at baseline, but also at 3 months and 2 years into the trial. And I apologize. Hopefully you can't hear the train that always passes through here in Augusta right outside our building at the most inopportune time. So with all of these previous studies, we being a kind of a math nerd by background, we decided to pool all this information that was available, as well as scouring the previous literature in schizophrenia to do a meta-analysis or a systematic quantitative review. And what we found, again, when we pooled a total of 8 studies looking at insomnia and suicidal ideation, we found a significant, almost 2-fold increased odds of suicidal ideation associated with insomnia. When we looked at suicide attempt, there was a non-significant association trending in the direction of increased odds of a history of suicide attempt. And then 2 small studies that found a significant association between the presence of insomnia and either an actual current suicide attempt or death by suicide. When we looked at associations with psychopathology, again, pooling largely our own data, we found small but significant correlations between insomnia and, again, total, positive, and general psychopathology. So having looked at first episode in chronic schizophrenia, we wondered, is it possible that this association even predates the onset of psychotic illness? And specifically, can we find similar associations even in patients with prodromal psychosis? So together with my colleague, David Goldsmith at Emory, we were able to collaborate with the Naples group, that's the North American Prodromal Longitudinal Study, to look at these associations in almost 700 patients at clinical high risk for psychosis. So as you can see, again, even younger than the first episode sample, about 50% male, about 50% Black, and a third white. And the Naples cohort has the Calgary depression scale for schizophrenia with its terminal insomnia and suicide item. Psychopathology was assessed using the SOPS, which is the scale of prodromal symptoms, and then another specific measure, objective measure of sleep, which is called the Pittsburgh Sleep Quality Index. And so what did we find? Essentially, we found significant correlations, no matter how you sliced it, whether you used the Calgary terminal insomnia item, whether you used the sleep disturbance item, which is specific to the SOPS, or whether you use the Pittsburgh sleep quality, either total score or some specific insomnia items. Again, broadly, consistently, we see higher total, positive, and general psychopathology, even in patients with prodromal psychosis. When it comes to suicidal ideation, again, we found particularly the SOPS and the Pittsburgh sleep quality items, both the total score and initial and middle insomnia items being significantly associated with suicide risk after, again, controlling for multiple potential confounding factors. So why is this? What might be driving these associations? And are there any kind of mechanistic clues that we might derive to understanding why insomnia might be associated with suicidal ideation? Well, what's very interesting, so Intercept was a very large trial of almost 1,000 subjects, randomized equally to either clozapine or olanzapine. And all of the patients in the Intercept trial had schizophrenia or schizoaffective disorder, and they were all deemed at high risk for suicide. They'd had a past history of suicidal behavior and were currently experiencing either suicidal ideation or they had command auditory hallucinations for self-harm. And so what do we know? We know that clozapine is the only FDA-approved antipsychotic with an indication for suicide prevention. And interestingly, what we noticed when we looked at the adverse event data for Intercept is that clozapine was associated with significantly less insomnia than olanzapine. My experience clinically is that olanzapine tends to be a very sedating antipsychotic. So I think it's very telling for the potent sedative properties of clozapine that there would be a significant difference between olanzapine, which we know to be very sedating, and clozapine, which we also know to be extremely sedating. Excuse me. So what we did is we looked, again, it's a publicly available database called FAERS, which is the US FDA Adverse Event Reporting System. And these are either patient, family, or clinician reported adverse events. And we looked at this database for events where any second generation antipsychotic was the suspected agent of a psychiatric adverse drug reaction. There was adequate data to look at 10 different second generation antipsychotics, and we calculated the reported odds of these adverse effects relative to clozapine. So we set the reference for both insomnia and any kind of suicide outcome, whether it's ideation, suicide attempt, or death, to 1. And what we found was that every other second generation antipsychotic was associated with a significant increased odds of insomnia and suicidal ideation or behavior compared to clozapine. And what was very interesting is if we plotted those two odds ratios against each other, we found a significant correlation between the two odds ratios. So again, not suggestive of causality, but certainly an interesting association that even using pharmacovigilance data, that odds of insomnia were significantly correlated with the odds of current suicidal ideation or behavior. What's even more interesting to me was that when you looked at the histamine binding affinity, clozapine actually has the highest histamine binding affinity compared to other antipsychotics. And when we plotted the risk of insomnia against that binding affinity, we found almost a near perfect correlation across 6 different antipsychotics. Again, raising the possibility that improvements in insomnia with clozapine, potentially directly mediated by its antihistaminic effects, may be driving some of the anti-suicidal properties of clozapine. We then performed a meta-analysis of the odds of insomnia in randomized control trials of clozapine versus other antipsychotics. So complementary to the pharmacovigilance data, we found that in randomized control trials that non-clozapine antipsychotics were associated with, again, about a 2-fold increased odds of insomnia, typically reported as an adverse event compared to clozapine. And so again, when we plot these odds ratios against each other, there was almost universal agreement between the randomized trials of clozapine in patients with schizophrenia, and simply adiagnostic pharmacovigilance data. So to take that a step further, we went back to the CATIE trial, and in phase 2 and 3 of the CATIE trial, there were 76 subjects who were treated with clozapine and had available data from the Calgary Depression Scale, again, the Calgary containing items for both insomnia and suicide, and they had data both before and after treatment with clozapine. And so at baseline, when these 76 subjects were started on clozapine, 30% had insomnia, over 20% had current suicidal ideation. And again, the presence of insomnia in these patients before they started clozapine, insomnia was associated with an over 4-fold increased odds of suicidal ideation. They were subsequently treated with clozapine. The prevalence of insomnia dropped from 30 to 11%, and the prevalence of suicidal ideation dropped from 21 to 8%. If we look at just these 23 subjects who had insomnia at baseline, again, 21% of those subjects had suicidal ideation. At follow-up, we found that the prevalence of insomnia dropped to 17%, and only 9% of these subjects had suicidal ideation at the end of treatment with clozapine. So importantly, we found that if their insomnia resolved with clozapine, that was associated with an almost 15-fold increased odds of resolution of their suicidal ideation. So again, further evidence bolstering the fact that if sleep gets better and clozapine helps our patients sleep better, that does drive a significant improvement in suicidal ideation. In terms of some new pharmacovigilance data, this is a manuscript that is currently under review. We went back and looked at the FAERS database, again, where a second-generation antipsychotic was the suspected agent of some kind of adverse drug reaction. And we were able to drill down specifically to look at individual cases where these suicidal behaviors and insomnia were simultaneously reported. So to show this graphically, FAERS has a listing of all the psychiatric adverse drug reactions. There's a subset of suicidal behaviors. There's a subset of insomnia adverse drug reactions, and we were most interested in that overlap here, the intersection where there were adverse drug reactions reporting both insomnia and suicide within the same patient. And so again, we found relative to clozapine, all other antipsychotics were associated with significant increased odds of suicidal thinking and behavior. And in patients with comorbid insomnia, those odds were even greater. So suggesting, in very simple clinical terms, that our patients with schizophrenia who still have persistent insomnia are at dramatic increased risk for suicidal thinking and behavior. So with that, I'm going to shift a little bit in terms of our current work using pupillometry. So hopefully I've shown you that these phenomena are connected. There seems to be these associations between insomnia and suicide and psychosis. Clinically, when it comes to preventing suicide risk, we're limited really by a lack of risk factors beyond kind of clinical demographics. The strongest predictor of future suicidal behavior is past suicidal behavior, and beyond history of suicide attempt, we know that males, older patients with comorbid substance use are at higher risk for suicide, but there's no practical point of care biomarkers that can be used to help supplement our clinical management. We know that as well that many patients may be seen in clinic, they may truthfully deny suicidal ideation, but they leave the clinic and within 24 hours, there's some kind of significant stressful event, and they may rapidly progress from from the absence of any kind of suicidality to suicidal ideation and behavior and even attempt. And anything that we could do to maybe identify those patients at higher risk in advance would have tremendous utility. So hyperarousal, increased arousal, kind of excess sympathetic nervous system tone is a candidate marker that may mediate some of these associations. And the pupillometer that I showed you is a potential practical measure of physiologic arousal. We use this handheld self-contained device. And this is what it looks like in the screen. It measures 6 different parameters of the pupillary response. After about 10 minutes of dark adaptation, we shine a brief pulse of light, and the pupillometer automatically measures, calculates, and reports these different parameters, including the pupillary diameter at the beginning and the end, the largest pupil diameter, the smallest pupil diameter, how fast the pupil constricts, how long of a latency period before it takes place before the pupil begins to dilate, and the time that it takes to get back to 75% of the baseline pupillary diameter. So the initial constriction, pupillary constriction, is largely derived based on parasympathetic responses. The MCV highlighted here is the maximum constriction velocity, the fastest velocity at which the pupil constricts. ACV is the average constriction velocity. And then there's a latency period, and then the pupil begins to dilate. And dilation is largely driven by sympathetic tone. So in a preliminary study, we looked at this in a trans diagnostic sample. What did we find? We found that in patients with either schizophrenia or major depressive disorder, that patients who were currently suicidal had significantly faster average constriction velocities. That is, their pupils constricted more vigorously, again, even after controlling for multiple potential confounding factors. When we look at this and its relations between insomnia, we found some significant correlations in patients with schizophrenia. Again, patients with more insomnia had more vigorously constricting pupils. So our next steps with this, we've been pursuing funding opportunities, haven't had any success yet, but hoping to get some funding either from NIH or the American Foundation for Suicide Prevention. With that, I'd like to say a big thanks to my family, to my lovely wife, Kelly, for her enduring support, and our 4 kids who certainly keep me on my toes. With that, I will stop and we can transition to any questions that you might have. But my biggest kind of clinical pearl for everyone is in our patients with schizophrenia and other psychotic disorders, patients who have ongoing insomnia warrants rigorous evaluation for depressive symptoms as well as a rigorous assessment of suicide risk. So with that, I will say thank you, and we can open the floor up for any questions that you might have.
Okay, excellent. Thank you, Dr. Miller. If you have a question and you're viewing online, please enter into the Q&A chat and we'll ask that for you. Do we have any questions or comments from the audience in the room?
Hey, Dr. Miller. My name's Dr. Fowler. I'm one of the psychiatry residents here at PGY3 and an
Yes.
alumni of Augusta University. I got my master's in clinical counseling. We appreciate you coming out and talking to us. I was a little bit late, so you may have covered this, but should this change how we approach treatment as far as Z hypnotics or other medications in association with folks with schizophrenia if clozapine is not something that we can use? Has that research been looked at?
Sure, it hasn't. It's a great question. We just had got unfortunately a negative decision. We submitted a large grant to PCORI looking at treatment of insomnia in patients with SMI, looking at, we had proposed to look at just trazodone, melatonin versus a digital cognitive behavioral therapy for insomnia. And so there's not, to my knowledge, any published data that have looked at this yet in terms of non-clozapine patients. I've perused the CATIE data, and it does look like if patients are already on hypnotics and they still have insomnia, that's associated with an even higher risk of suicidal ideation. So my personal preference is to be really aggressive about treatment of insomnia. How do I do that? Well, we know that antipsychotics can be very sedating. So if it's possible to make some adjustments in the dose of just the antipsychotic, whether that's olanzapine or quetiapine, for example, that may be helpful in and of itself to address the insomnia. But I use a broad range of pharmacologic options, including melatonin, trazodone. I certainly do use Z drugs in patients with schizophrenia. If they've failed other agents and there isn't, concerning substance use history, for example, my preference has been to be pretty aggressive about treatment of residual insomnia. So that would be kind of my clinical recommendations, not necessarily an evidence-based one, but based on the associations with suicide. I tend to be pretty vigilant in treatment of insomnia. That's a great question.
Thank you, Dr. Miller.
And if I may, I might also add, without getting into details of lots of the studies, many of these papers, secondary analyses of existing data sets, pharmacovigilance data, all of these were done. I think just about every paper had a medical student or resident who was involved in this collaborative research. It was a great way for students to get involved in research. Many of them ended up being first authors on these papers. So this is the kind of thing that can be done at the trainee level to get some experience with research. And there's a lot of great opportunities to kind of mine these existing data sets.
Dr. Miller, I wonder if you'd be so kind. Did they try to subdivide this insomnias either to central or peripheral?
Unfortunately, no. Unfortunately, we're using very crude kind of self-reported measures of insomnia. As a future direction, it would be particularly valuable to get risk activity. We can't put everybody obviously in the sleep lab, but to get, for example, risk actigraphy to kind of get a more objective measure of sleep might be a future direction there. But at present, the reporting of insomnia tends to be at a pretty crude, granular level.
Thank you, Dr. Miller, for a great talk. My questions had two components. One,
Sure.
recently there was the FDA meetings done, literally as of yesterday, when they are thinking of removing clausural REMS restriction, and sooner than later it's going to come. So with that, I'm expecting more use of clausural, especially for schizophrenia. Have you ever thought of expanding your studies into bipolar? And has clausural ever been looked at bipolar mania with psychosis, bipolar depression with psychosis, and suicide prevention? And what's your prediction as to where the next wave will go?
Sure. Those are some great, thoughtful questions. I have not focused on bipolar disorder, but it would not surprise me. We've seen it in depression. We've seen the associations in schizophrenia. I think that this is a very transdiagnostic phenomenon. And so it would not surprise me in the least to find associations between insomnia and suicide in bipolar disorder. And I would strongly suspect that when used for mania or psychotic mania, treatment resistance, that we would see similar benefits of clozapine on improving sleep, improving suicide risk in our patients with bipolar disorder. A great example, we think about you may be familiar with, it's called the BSNP Consortium. That's the Bipolar Schizophrenia Network for Intermediate Phenotypes. It's largely based out of UT Southwestern in Dallas, and they have looked at patients with schizophrenia, schizoaffective disorder, and bipolar disorder with psychotic features, and sort of finding that if you looked at more objective measures, MRI findings, EEG parameters, that you can identify more biologically homogeneous subgroups of patients based on these more objective measures that cross all three diagnoses. So my personal opinion is that DSM is designed for reliability, but not validity. And so it doesn't really tell us anything about the underlying pathophysiology of these illnesses. And so I think any ways that we can sort of slice the pie to identify more homogeneous subgroups of patients, regardless of the specific diagnosis, will certainly help. An interesting word of caution regarding your comments on REMS. I have a very unique clinical case, a patient with schizoaffective disorder. She recently experienced agranulocytosis after 6 years on clozapine. Essentially, for the first 5 years, had completely normal blood counts, and then started slipping, and then kind of rapidly fell off of the slope. Did not have any opportunistic infections, but neutrophils dropped to 100. We followed all the monitoring guidelines. We consulted hematology, who did a bone marrow biopsy that was negative for any kind of underlying pathology. In the meantime, this woman has very severe psychosis, was very adamant that she wanted to restart clozapine if at all possible. I maintained her for a couple of months on 60 milligrams of olanzapine a day. And after hematology consultation, they agreed to restart clozapine with a plan that if her counts drop again, that they will administer her colony stimulating factor and potentially antimicrobial prophylaxis if her counts were to drop again below 500. So I understand that REMS is a barrier to clozapine use. To borrow, we have the famous chicken restaurant in Georgia that has the slogan "Eat more chicken." As a psychiatrist who treats lots of treatment-resistant psychosis, a parallel sentiment is use more clozapine. But I will say that the monitoring guidelines are designed to be protective, and in this case, we could have had a very severe outcome if we weren't continuing to monitor. I know it's an isolated case, but something that I've not seen in almost 20 years. So.
All right. Thank you, Dr. Miller.
Thank you so much. Appreciate the chance to be here virtually, and wish you the great rest of your day. Thank you very much.